it working, sir? Thank you. I have no disclosures. So energy loss of blood flow in the TCPC in Fontan patients has been linked to adverse clinical outcome, and areas of increased energy loss may therefore also be present in the area below the TCPC. The region where the inferior vena cava, hepatic veins, and the extracardiac conduit join, the IVC-ECC junction. The objective of the study was to assess the geometry and flow patterns in this region and to determine the blood flow's kinetic energy and viscous energy loss using 4D flow MRI. The study included 14 patients, and the patient's characteristics are described above. The IVC-ECC junction consisted of the first 2 centimeters of the conduit and comprised 6 centimeters in total, as shown on the image. The hepatic veins were shown here for orientation purposes only, but were excluded from the 4D flow analysis due to insufficient spatial resolution. And the calculated energetics were normalized for volume and were compared with the observed geometries and flow patterns. So the IVC-ECC junction showed to be highly variable, including relatively straight IVC-ECC junctions with no flow abnormalities in nearly half of patients. In a subset of patients, there was a significant increase in blood flow velocity from the inferior vena cava towards the extracardiac conduit, representing IVC-ECC mismatch, and showed increased energy loss and kinetic energy. And in 4 patients, we saw highly distorted geometries leading to acute changes in flow direction and the occurrence of helical flow patterns, and were also associated with increased kinetic energy and energy loss. So concluding, the IVC-ECC junction was highly variable and included relatively straight connections where no flow abnormalities were found, IVC-ECC mismatch, and distorted geometries leading to adverse flow patterns. And these abnormal geometries and junctions were associated with increased kinetic energy and energy loss and may therefore be relevant for Fontan patients. Thank you.
Thank you. Interesting. So some of your patients had a 16 millimeter conduit. So is that what you regard as being a mismatch, and would you not do that anymore?
Yeah, so there was indeed, we had 7, so nearly half of patients had a 16 millimeter conduit. And when we looked at, it was not included in the presentation, but when we looked at the mismatch, which we defined as the velocity increase from the inferior vena cava towards the conduit, we found a strong correlation between body surface area and mismatch in these patients, indicating that these 16 millimeters in these patients are indeed too small. But we could not say anything about the 18 or 20 millimeters because we had only very limited numbers of these patients. So these, we don't know if these are large enough for the growing Fontan patients.
In follow-up to this question, did you confirm that this 16 millimeter or the mismatch was not, or the deformed geometry was not the surrogate for this turbulence? That not the 16 millimeter, but the non-straight geometry was the cause for the turbulence. I'm maybe not clear. You know, there are straight graphs, straight flow with 16 millimeter.
Yeah.
And there are deformed geometries with 16 millimeter.
Yes.
Do you think what is important? Is it 16 to, or the mismatch is important, or the geometry is important?
Yeah, that's a good question. Well, the numbers were too low to make subgroups of each contribution, essentially. So we don't know if it's predominantly the mismatch or it's also the geometry we see, because we could not make subgroups with only patients who had only distorted geometries but no mismatch. So there may be some overlap. So that's.
I just want to comment that we have implanted 16 millimeter over years and none of them has been removed. And as a follow-up, we have started putting bigger ones now since few years, but we all know problems of oversizing on the potential compression of the pulmonary veins.
Yes.
Kristen?
And what is going to be the next step? Are you going to CAT these patients to measure pressures or pressure gradients, or are you going to reoperate some of these? What do you think about it?
Yeah, that's difficult because these were all randomly selected patients, so none of these patients received the MRI for clinical indications. So it was, or as the 40-flow MRI for research purposes when they also had the MRI for normal follow-up. So these patients were essentially asymptomatic. So I think it's quite, you cannot conclude from this small sample size to say, well, we have to operate, but it's at least something we were quite surprised of, that we, well, essentially the straight junction was what we expected to be present in all the patients. But there was, only in these 14 patients, there were still 4 patients with that really, really strange angles with more than 90-degree bends in the conduit. Yes, so that's certainly we have to further investigate with better anatomical scans and better, more large.
Professor Dudekem is here.
Sorry.
I like the study, and I think that I agree on the fact that I actually think that we don't pay enough attention to the anastomosis when we do the Fontan. I personally looked at the patients who had Fontan failure, and there was a lot of patients in the series who had a PLE, who had minor kink, and I don't think if you do a cath, you don't find any gradients in these, but it's just not a normal, nice anastomosis, and following that, I tend to do more anastomosis now when it's not perfect and it's not the right setup. I put a groin cannula to do an open anastomosis to have a better lineup. Did you look at pleural effusion drainage, PLE incidents? You say they're asymptomatic, but you may have surrogate marker of patients who are not doing as well?
No, I actually didn't look at it, so I'm not sure. But so current work of our group is now to look at with this 40-flow MRI technique in the whole TCPC. So essentially, what we think that this is an extra geometric factor that can be important, can give some resistance, but we should also include the whole conduit and the pulmonary arteries. But I think, yes.
I encourage you to look back at the duration of pleural effusion drainage, because it's a very good surrogate marker or long-term outcome. It's reliable, and it's fairly easy to find out in your...
I will. Thank you.
Yeah. Any other questions? Also, the questions here, sorry.
Nice data. Quick question. The first graph there almost looks like a lateral tunnel. It's a straight shot up there. Do you know if but obviously it's an extracardiac conduit.
Yeah.
When it comes to the technique of how this is done, did you find out any correlation about those patients where the IVC-RA junction was completely amputated and then the graft was sewn in versus, I know there in some, centers, they leave some of the IVC attached to the right atrium, and therefore the extracardiac conduit sort of comes in lateral and makes a loop to go up. Did you actually have any of that data?
I'm not sure. Maybe I can pass this to Professor Hazenga.
Yeah.
No, they were completely amputated and sewn in, and that was the
that would not
standard
play a
way to do this. These
Yeah.
patients were randomly sampled for this study. They were completely asymptomatic
Yeah.
and had normal echo and normal angiography. So we think that this is an other, more sophisticated way to look into this matter.
Yeah, it will be important to follow these patients over time and find out, how many of those really, is this going to be clinically something, or it's just a nice image, and just, for example, plexic bronchitis, PLE, things that, that were mentioned before.
Tom, you had a question too?
I really enjoyed the presentation. There are 3 excellent papers in the literature dealing with this subject, probably more that I haven't read as well. One from Japan, one from Germany, and one from the US, suggesting something that's slightly different, that if you oversize the conduit, then the energy losses become significant. And also there's penetration of SVC flow into the body of the conduit, and disturbed flow in the lateral portion of the conduit. And this is in the clinically important range, somewhere between 2-to-1 and 1-to-1 mismatch. And in clinical practice with a 20 or 22 millimeter conduit, depending on the age of the Fontan and so on, it's actually more likely that you'll have a mismatch in the opposite direction. That is, the conduit will be bigger than the IVC. Whether this is important clinically, I don't know, but the point is, someone made a suggestion at Eve that we should look very carefully at matching the conduit to the caval size somehow. And unfortunately, the anthropometric data that we have for normal patients doesn't seem to apply to univentricular heart patients, and it's quite difficult to get this number just right. You could say maybe it's not clinically important, but of course with the Fontan patients, everything is clinically important.
Yeah.
But very nice presentation.
Is there any impact of ventricular morphology, let's say dominant right, dominant left, or of the position of the heart on flow dynamics? So can we estimate in advance which patient will have good flow, which patient will probably difficult to achieve?
So most of the patients, they had all like normal left-sided heart, and there was a normal connection. There was one patient with extracardiac, and that had a very, very nice, it was from the opposite side, inferior vena cava, but had a very nice, smooth path. But the other of the patients were, they had normal position of the heart. And I haven't looked at the morphology of the ventricles, but I'm not sure if that's have impact on the.
Okay. But since so Christian, from your comment, does that mean you use the lateral tunnel? You think it's better dynamics? Because
the data that if you looked at what was it, Francesco Migliacca from here and Marta Laval at Beauvais, they did a study looking at the overall flow dynamics, and I think that computational flow dynamics, and if I recall correctly, it seems like they demonstrated that in terms of energy conservation and avoiding energy dissipation, that hemifontaine lateral tunnel actually had the best energy conservation.
do you have any you could study lateral tunnels? Yeah.
So that's we're currently working on that.
Yeah.
So but they are older, obviously, because we changed.
Because the extracardiac really seems to be by far the most popular around the world. Who here uses the extracardiac conduit for their fontaines? Yeah. So that's probably 85%. And how many lateral tunnels? Yeah. So you see, you might be right after all. You never know. Yeah. Right. Well, one last comment to the front.
Thanks, David. I agree actually with Tom said actually about the mismatch of the IVC size and the conduit. Now, the other thing actually that I find that sometimes the IVC is surprisingly more anterior than what I expect, and in other patients it's more posterior. So I don't know if there is any way you can correlate the sort of acute angle in those patients in which the IVC is more posterior, and you have to run the conduit slightly more longer to avoid impinging on the pulmonary veins. So I don't know if there is any way you can look at your preoperative cross-imaging data.
Yes. So you see it also from this side, because you now look at the right lateral view. It's not changed, but there is indeed. It flows from parallel to the vertebral column, and then it goes a bit anteriorly to where it normally connects to the right atrium. So this is actually the normal way you would suspect it. And maybe there is some slight difference between patients about the anterior movement of this. But essentially, these connections, where they are extremely distorted, I'm not sure if you can preoperatively identify those patients already. But we essentially don't know.
We have to stop. We're at time. Very good. Thank you.
Thank you.